Health and Wellbeing Board. Good morning to everybody. Thanks for coming. And the first item, it's a nice sunny day. You don't get that very often. And also I especially welcome Sam Allen and Dr. Catherine Bush, who are going to make some presentations here. So let me begin with any apologies for absence.
Apologies from Councillor Glenn Sanderson and David Thompson.
David Thompson. Is there anyone else who sent apologies? No. Thank you. Minutes of the previous meetings, I went through them, and I don't see any mistakes. Are there any comments on the previous meetings minutes? Thank you very much. Disclosures of interest. It's a formality. Is there anyone who has to declare any interest here? No. So let's move on. So that brings us to Sam Allen, who is going to make a presentation, ICS update. Thank you. Welcome.
Of the North East and North Cumbria Integrated Care Board. What I've been asked to do is give a bit of a presentation today just to provide an overview of the role and function of the Integrated Care Board, and perhaps what you'll be aware of as being probably some of the more significant structural changes to the NHS in the last decade. So quite a few things changing, some things staying the same. And I hope that when we get to the end of the presentation, Chair, we'll have the opportunity for questions and indeed comments. So, we do like a three-letter acronym in the NHS. The terms ICS, ICB and ICP seem to be used quite interchangeably in a lot of language. So I thought it'd be helpful just to start just by explaining these. And for those of you that I've seen at other health and wellbeing boards, I do apologise in advance for you sitting through this presentation again. So the integrated care system, when we're talking about the integrated care system, it's not a statutory organisation. It really is a partnership, and it's a collection of organisations, public sector, statutory bodies, the community and voluntary sector, fire and rescue, police, education. It's a number of organisations who come together and have an interest and have the opportunity to contribute to the public health and well-being of communities and our population. So it's not an organisation, it really is a partnership. The Integrated Care Board, the organisation I'm the Chief Executive for, is the new statutory NHS organisation that has taken on the responsibilities of the 8 clinical commissioning groups that existed in the North East and North Cumbria, the Northumberland Clinical Commissioning Group for Northumberland. And the Integrated Care Board is one of 42 statutory bodies across the NHS in England. Whilst we're only just the largest, it would be fair to say we are the largest of the 42. The map with the little numbers sets out all of the integrated care boards. The yellow blob down being London. We are the largest in terms of geography, but also the largest in terms of the population size, 3.2 million people across the North East, North Cumbria. Another really important part of the integrated care system, alongside the Integrated Care Board, is something called the Integrated Care Partnership. And that is a joint committee of the Integrated Care Board. And it's a joint committee that's made up of the voluntary sector, of patient forums, and of the 13 upper tier local authorities that sit in our Integrated Care Board. Soon to be 14 from the beginning of April next year, with the 2 new unitary authorities being created in Northumbria. In Cumbria, it has a really important role its core purpose is to set what's called the integrated care strategy for the Integrated Care Board. So to develop the strategy for the whole of the region. The Integrated Care Partnership will meet in the North East North Cumbria for the first time next month, and its membership is made up of the 13 chairs of health and wellbeing boards and a local authority officer, and also the Integrated Care Board. And I'll be able to go through the members of our Integrated Care Board on a future slide. So what is this about really, and why is it different? I think we're all probably used to, those of us that have been around a long time, I've worked in the NHS for 25 years, have seen a number of changes in our time. They usually come along every 5 to 10 years. The key difference with this change in terms of what the legislation set out to do is it's really about being ambitious for our population, but with an absolute focus on health inequalities. So these are the 4 strategic aims that government has set the Integrated Care Boards. The first one being improving the outcomes in population health and healthcare. And I do just want to kind of pause briefly to distinguish between the difference between health and healthcare. So if we think about healthcare services, we think about making sure that we've got responsive healthcare services, they're accessible, they're a good experience, they're of the right quality and the right standard. If you think about somebody's overall health as an individual, in part, their health and health outcomes will be determined by having good access to healthcare services of the right standard and of the right quality. I think here in Northumberland, we're really fortunate, I think, in terms of the healthcare services we've got available, both whilst there's always room for improvement in everything, both in primary care, general practice, but also in our hospital and community-based services. But actually the vast majority of somebody's health is determined, as you know, by those wider social determinants. The type of issues that you as a Health and Wellbeing Board will be very focused on in terms of thinking about where people live, the opportunities they have, both in education and employment. And I've been really pleased to see the work that has been taking place here in Northumberland across health and care, particularly looking at the health inequalities that exist in the communities that you serve. And also thinking of that in terms of the context of the rurality of the communities here in Northumberland, the coastal aspect, and also the more urban areas. So we've got a task, which is we have to improve outcomes in population health and healthcare, hence the reason why the integrated care system and all partners working together, whether it's our community and voluntary sector, our statutory public sector organisations, but also thinking about the broader social and economic development in terms of industry, particularly, as I said, around employment opportunities. We know that there's always a direct link between wealth and health. So we've got to tackle those inequalities. We've got to make sure that we've got fair access, fair outcomes, and fair experience. And people's health isn't determined by solely by where they live. And we've got to make sure and really think about equity. So the government may use the term levelling up. We think about it in terms of equity, targeted support, targeted interventions, but really deeply knowing our communities, that we can organise our services and our offerings together. And then just finally, just touching on the productivity and value for money, it is incumbent upon us to work with all of our partners across not just the NHS, all of our other partners, to really make sure that we are as productive as possible and that we are delivering services and outcomes that represent best value for money. And what I would say is, starting to look at the data across the North East and North Cumbria, we know that we've got some what we call warranted variation, which is explainable and variation that we can tolerate given the differences in our communities, but we also do have unwarranted variation, particularly when we look at some of our outcomes and data across our hospital-based services. So just to touch really on some of the challenges that we've inherited, and again, this won't be new to you because you've been working on these together. We have sadly inherited some of the worst public health outcomes in England, the North East. This has been well known, and something actually that's building on a century. It's not something that has happened in the last year. This has been decades. We know that in terms of years of healthy life expectancy, we are starting to see a slight reduction in that. And we also know in some of our communities where the health inequalities are more significant, there's a very significant impact on life expectancy. And we're really thinking also in terms of years of lived life. So these are quite persistent, they're out there, and as I said, I think it's really good that in Northumberland you're closely examining these, bringing in some expert inputs to that. We've got consistently increasing demands on emergency care services, which you'll be well aware of. And we've also had the challenge of restoring elective services after COVID. What I would say on that is in the North East and North Cumbria, in terms of the first goal, which was to eliminate the number of people waiting longer than 104 weeks for their elective procedure, we ended at the end of July with 49 people still waiting 104 weeks. All but 2 of those were because of very complex surgery where choice had been offered. So actually, when you look at the performance comparatively with other parts of the country, we're not doing too bad, but there's a huge amount of work to do, particularly around the next goal, which will be 78 weeks, and then 52 weeks. So this isn't something that's going to be resolved in the next few months. This is going to be ongoing work for the next couple of years, particularly with those care backlogs that built up during COVID. And it doesn't just relate to our hospital-based services, it also relates to our community-based services, and particularly the increase in demand for example, mental health services for children and young people, again, is well documented. We do have some disparities in access across the Integrated Care Board. If you think about 8 clinical commissioning groups, if you think about things like clinical guidelines, and if you think about decisions on things like which treatments to fund, they do differ. So we've got some work to do there in terms of making sure that we've got consistency. And also, like anything, we have work continuing and underway in terms of the staffing structures. We are doing our utmost where we can to limit the impact of that, but there are and there have been changes, and there will continue to be some changes with that over the weeks ahead. So we'll make sure that these slides are available. I won't go through all of these, but what I wanted to do is just give you some sense of what's called sort of continuity and change. So what will stay the same for local authorities absolutely is the statutory role of this board, the Health and Wellbeing Board for the Population. That doesn't change. As I said, we want to develop our integrated care strategy with the inputs of the joint strategic needs assessments that have taken place across the North East and North Cumbria to develop that strategy. The duty to collaborate between organisations will change. Will not change, but there has been now a legal duty put in to collaborate. So what we are expecting is that we perhaps will see less competition, and in fact I think competition and competitive tendering for services should be by the absolute exception in the future, and what we would be seeking to do is collaborate where we can across our services. We will continue to have NHS representation at this Health and Wellbeing Board, and in Northumberland we have established our place-based team, and it's great to see Rachel here, who is our Director of Place, and Rachel will be well known to many of you, having worked here for a number of years. We would be looking for further opportunities for joint working between health and local authorities and indeed across the whole of the public sector. And with particularly our work around economic development, we are also working very closely with the combined authorities across the North East and North Cumbria. Whilst I am the accountable officer and responsible for a budget of nearly 6 billion, I see one of my core roles being about job creation in the region and making sure, as the largest employer across the region, we can provide opportunities for people of all ages to choose a career in health and care. And I think, Chair, it would be fair to say that one of the areas where there's been most interest in working closer together has been on our workforce. But what will change? We have one integrated care board now, not 8 clinical commissioning groups. We are going to maintain a local presence, though, and we have our offices here in Northumberland. From a ICB perspective, we will be locating our head office in Sunderland, but we're very much out and about right across the patch. The creation of that statutory integrated care partnership is new and is a change, and as I said, that will meet for the first time next month, as is the integrated care strategy for the whole of the North East, North Cumbria. And our first integrated care board at the beginning of July, it is available to view if you missed it. We do screen it live online. You'll see us talking in that board meeting about the development of the strategy, and over the forthcoming weeks we will be doing a lot of engagement, public engagement across communities to support the development of that strategy and indeed strategic choices that we will need to make around our priorities. And as I said, we've got a real procurement commitment to support broader social and economic development, and I think one of the things we're very committed to do is making sure as many of those NHS pounds stay in this region as possible. Again, and then just finally, that whole renewed focus around health inequalities. And what I would say is, particularly given some of the challenges with the recovery from the pandemic, with the addressing the care backlog, we'll need to make sure that we, in addition to tackling some of our operational priorities, stay absolutely focused on what we need to do to address those health inequalities. And I think, whilst there are some similarities when you look at ward level data, one of the, and I did have the opportunity a couple of weeks ago to spend a day in the north of Northumberland, getting right up to Berwick-on-Tweed. I think the rural aspects of Northumberland, whilst share some characteristics with North Cumbria, is quite different. And I think we, in our development of our health and care strategy, we're going to have to really make sure that we have a strategy that meets the needs, as I say, of our rural communities, urban and coastal. Just to give you just a sense of our leadership team, and again, what's different about the Integrated Care Board, it's not like a traditional NHS board. So on our board, we have our chair, Liam Donaldson, and we have 4 independent appointed non-executive directors. We have the executive team that are listed here, but we also have partner members. So we have a Director of Public Health, a Director of Adult Social Care, and a Director of Children's Services. Primary Care. We have 2 partner members from the 11 NHS Foundation Trusts, one of whom has clinical experience in mental health, which is a requirement for the board. And we also have a representative from Health Watch and the voluntary sector. Just in terms of the partner members, these the construct of our board was developed over the last year through a joint management executive group of which all the authorities and NHS organisations were represented on. And our partner members that are drawn particularly from our local authorities have been through agreement and discussion with the Directors of Public Health Network, with the Adult Social Care Network and with the Children's Services Network. And you may see that we've one of our requirements, in addition to having them as members, was to make sure that the parts of the North East and North Cumbria were represented. So just to touch on a couple of things here, I won't go through this in detail, Chair, but just to say, because I think one of the key questions that has come up quite rightly throughout this is, well, how are we going to take decisions? Where are they going to be taken? So what this slide really does is summarise ICB functions and decisions that we take at a regional level and those that are discharged at place. We've always said 22-23 is what we're calling a transitional year, setting up the new organisation, establishing the governance, and we held an event, and it was good to see yourself, Chair, at that event with some colleagues here in Gateshead at the end of the June, where we talked about the development of governance at place. What we would want to do, what good would look like, is that we've got clear governance arrangements at place, and we've got delegated decision making for as much of the resource that we're responsible for the planning and delivery of the communities here in Northumberland happening at place, and that will be developed over the months ahead. As I said, we'll be setting the strategy, very much built from place, but setting the strategy and agreeing that at the Integrated Care Partnership, which is the regional event. We've also taken on some new responsibilities. For example, we're now what they call a Category 1 responder for emergency planning, where CC clinical commissioning groups were Category 2 responders. So we've had to establish a whole infrastructure around that, and obviously working with our local resilience forums. I think particularly around innovation and workforce planning and the opportunity to share learning. One of the things that's been quite stark is we have an abundance of innovation and good practice right across the North East and North Cumbria, but we haven't been as good at sharing that consistently. And that has been feedback that's been fairly consistent from wherever I've gone and whoever I've spoken to. And we'll be holding an event in September where we will be starting to co-produce the development of our learning and improvement system for the North East and North Cumbria. I mean, I've absolutely waxed lyrical about my visit to the north of Northumberland a couple of weeks ago. And in fact, when I was in Cumbria last week, talking to them about some of the innovative work they've done with paramedics there, the work the GP practices are doing. As I said, there are examples of that everywhere you go. We need to get better at sharing it across the region, and that's something we're committed to doing. So just on our integrated care partnership, so whilst we have the one integrated care partnership for the North East North Cumbria, in developing the constitution for the ICB, it was felt very important that integrated care partnership was built up from place. So we have 4 sub-ICPs that we're calling them. The one for Northumberland is linked, is the North of Tyne and Gateshead ICP. So that includes Northumberland, North Tyneside, Newcastle and Gateshead. So what I would anticipate is the Integrated Care Partnership, as I said, meets in September. That will meet twice a year. The sub-ICPs will be meeting more regularly, pulling together, talking about their priorities and making sure that as an area they are informing the health and care strategy for the region. The role of these integrated care partnerships system-wide, as I said, meet annually and biannually. It'll be a strategic forum. It will sign off the strategy. It will really promote that multi-agency working. It will look at some of the more larger scale aspects of work that we'll be doing. Those more locally focused, that North and North of Tyne ICP that Northumberland sits within, will meet much more frequently. It'll have a really key role in analysing, pulling together the JSNAs, sharing intelligence, agreeing shared objectives. And indeed, at the moment, to some extent, there is a meeting, for example, of leaders and chairs, leaders of councils, chairs of the NHS organisations that come together regularly. We will be including our place directors, and there'll be some other members, but we'll be shaping the membership of that, and it will meet far more frequently than the biannual meeting. I'm not going to cover the final slide, Chair, because I've touched on this already, but this really sets out our journey to the place-based governance, which has been the key decision really in terms of making sure that the community, the population's needs here in Northumberland are going to be adequately met through this new arrangement, but also ensuring that we get to a place where we've got effective governance so that we can delegate, as I say, decision-making and budgets to place, to Northumberland, and that is where we want to get to over the months ahead. So thank you, Chair. Thank you for the opportunity to come along. I'm not sure how we're doing for time, but it'd be great to get any questions.
Thank you, Sam, for that excellent overview. And I think we are open to questions now. Are there any questions? Liz.
Thank you. Obviously, there's been quite a few NHS changes over the last few years. How do you think this is going to be different? What is going to make it different from all of the others that we've experienced?
Yeah, there have been quite a few changes, Liz, and they're not over yet. So we've had arm's length bodies changing. I think for this, it's the first time, certainly in my career in the health service, we have seen such a focus and a statutory duty in legislation on health inequalities. So I think that will change. I think also the health and care strategy over a 5-year period, and there's been a commitment also to get into a longer financial settlement where we've worked on annual cycles of settlement, which makes it incredibly challenging. What I would say though, and I think it's really important to that we I think acknowledge this. It's probably coming at perhaps what some would say has been the most challenging time, but not just for the NHS. I think all public sector services and the wider community. So I think the opportunities to harness, particularly if the forecasts are right around, for example, economic recession being on the horizon, the opportunity to harness and address our vacancy issues across health and care services and have more sustainable services. I think we have a bit of a burning platform that we need to seize with that. But I think it would be the health inequalities and the longer term planning that to me are the big differences.
Jeff.
I've noticed that we're putting things together and making a bigger thing. We've always had a problem in dealing with our extremely remote areas, like Kielder, most people don't even know exists, but places like Berwick as well. If we make the area bigger, how are we going to ensure that those places aren't forgotten? And how are we going to ensure that those people have as much right to services as anybody else, and that equalities are not just about the southeast of Northumberland, but about the whole county of Northumberland?
Yeah, I honestly think that we have to make it more visible. We have to make it more visible. I gave evidence to a select committee about 4 weeks ago on rural mental health, and I think we have some challenges in terms of, and the Nuffield Institute's reported on this widely, in terms of things like financial allocations, because quite simply, delivering healthcare in a rural setting is very different from delivering it in an inner city. It's different. And it requires all sorts of ingenuity and creativity in many ways, and also the population needs are slightly different too. So I think we need to make it more visible. I think we need to understand it, and I think we've got the ideal opportunity with the work we're starting now on our new health and care strategy to make sure that it has its own section in the strategy because it is different. But I think we also need to have more conversations with the people who work in those communities, the people delivering care in those communities. And we also need to remove some of the barriers that they experience. So just my visit recently, I came across quite a lot of bureaucracy where approaches have been developed and are implemented nationally on a one-size-fits-all. The additional roles, for example, in primary care services, is a great example. So we need to fix some of those things, and we need to make sure that we're making it far more visible and we understand it.
Thank you. Wendy?
Thank you, Chair. My name is Wendy Patterson. I'm the portfolio holder for adult wellbeing for Northumberland. Thank you so much for coming along today. It's greatly appreciated. What I wanted to say was inequalities is absolutely huge, and it seems to be the buzzword of the moment, but I can remember inequalities being discussed in the 1980s. So this is not new. And I don't think we've made terribly much progress because the North East is still figuring as the worst area, I think, in England for poverty, all sorts of things. So my first question is, where do you start? Where will you focus on? And my main concern is, why are people in the North East dying in deprived areas 5 years earlier than people in a deprived area in London? So I would love to know why.
Yeah, thank you, Wendy. So where I think you're right, you're absolutely right. Where do you start, I think, is actually where you have started here in Northumberland. So I think the Health and Equality Summit that you had, bringing in the external experts, understanding the data, but also getting to the communities to ask. And I think also what we mustn't do is sit in, to be perfectly honest, sitting rooms like this and come up with solutions. A lot of the solutions are out in our communities. So I think, again, it's a bit like the rural issue. We need to really understand it and deeply understand it. Some of this is deeply, deeply rooted in communities. And I think, again, getting to the heart of these reforms in the NHS on its own will not solve them. This will be solved by working together, but also working with community leaders, faith leaders, and people in our communities. I think the issues are linked into a number of things: environment, availability of resources, a legacy of industry, and the need to really, and again, I think the work that you've done as the council here, particularly around leisure facilities, absolutely fantastic. So it's about the whole environment, but also it's those wider social determinants: the quality of housing, the affordability, breaking some of the cycles that are deeply entrenched in some of our communities. So as you say, it's not been decades. This has been a century. It's gone slightly further back in the last decade, and sadly in the last 2 years, it's just been published recently, the North East is now the leading area for the number of children living in poverty, 2 in 5 children living in poverty. And we know with the cost of living increases, this is something that is a real urgent need for us to address. So I think where you start is where you started, the summits, learning, examining. What I would say is I don't think we need any more reports telling us. I think we've got enough reports, but I think now we need to get into concerted action. And my understanding of the summits that's happened here in Northumberland and the work that's underway is that is going to lead to clear plans, prioritisation. We won't be able to address everything, but let's be clear about where the priorities sit, and then make sure that we are, as I said, one of the areas we've got is around equity. Some of our communities may well need more than others, and I think that's a difficult, uncomfortable conversation to have at times. But if we're serious and meaningful about addressing health inequalities, those are the type of conversations we need to have together.
Thank you. Dr. Jane Lothian? Yeah.
Hi Sam, thank you very much. I'm Jane Lothian. I'm a retired GP and I run the local medical committee, which is the statutory representative organisation for primary care and GPs. We have met before at other meetings.
Online.
Yeah, online. And I just wanted to say I'm very, very pleased to, thank you very much for coming here today, and I'm very pleased to hear about the evolution of the thinking towards place. And also you referred obviously to the inequalities and to the workforce issues. But I just wanted, and you've had a chance obviously to examine Northumberland briefly. What I really wanted to stress here is that the remoteness also places restrictions on the pool of people that you have available. And a lot of people in this room, we have been working together probably for 15 or 20 years in various guises and mixing and matching. And with every NHS organisation, and as when you said, it's not new. Some of us sat and listened to Stephen Singleton when he introduced the Health Action Zone in 1999, which had probably exactly the same ambition as we have now. So the plea is, every reorganisation, the organisation is split, it's injured, and its people are injured. But we have limited numbers of people, and I'm talking about managers and clinicians, and we can't just go to another suburb of London because there are no people. So I'm just saying we've been working together for 20-odd years or more, much more, and those relationships are the social, the managerial, the clinical assets that you've got. Please, can that be remembered in the remote category? Because we haven't got a bigger pond to fish on, and I see primary care struggling at the moment. The rest of the country's has had the pneumonia. We're just about catching a cold. So, you know, you've got a great asset here and a great set of people who've been working together for a long time.
Yeah. No, I couldn't agree more. It's been one of the things I've been most impressed with in relocating and moving up here. Although it has felt like coming home, having lived in Northumberland as a toddler, coming home. It is the people, the real sense of civic pride, the can-do, the connection with the communities. People live, they work in the communities, and I think, as you say, those relationships run deep. So we will do our best around treating those assets in the best way we can. And I think, like any organisational change, there will be things that we just simply don't get right. And I think we'll be open and honest about that, where we don't get things right, and we're open to that feedback. But I absolutely hear what you're saying, Jane.
I think mine's limiting the collateral damage or age or
yeah, thank you.
Next, please.
Good morning.
Morning.
Thank you very much. My name is Paula Mead. I'm the Independent Chair for Safeguarding Children and Adults in Northumberland. And it was really heartening to hear you make reference to children and young people so often that you do, because that can sometimes not be sidelined, but be less important in the NHS maybe than some of the other issues. So we've had a really good relationship with the CCG in terms of integrated safeguarding, working together with both adults and children, and I'd just like some assurance from you that that's not going to change, and that a place-based sort of response to safeguarding will be maintained through the new arrangement.
Yeah, absolutely. Will be very much maintained. And actually, we should follow up, Jane, because my chief nurse, David Purdue, and we've met with a number of the other chairs of the safeguarding boards just to talk about the governance, but the place arrangements will be unchanged when it comes to safeguarding. What we will have, though, is we'll have that opportunity on occasion to look right across the North East and North Cumbria in terms of some of the strategic themes coming out of safeguarding. And I do think children and young people is a very big theme right across the patch, but the local arrangements will stay the same.
Alistair, thank you.
Hi, Alistair Blair, one of the Executive Medical Directors at Northumbria, FT. Really good presentation, thank you very much indeed, Sam. I suppose my question, and it's more of, I suppose, a plea, is that it's great that we've got a focus on health inequalities, but we also, and this is, I suppose, a health and wellbeing board-wide thing, that the amount of health inequalities that are amenable to NHS and healthcare is actually quite small. And I really, my only concern, and it's great to have this focus, is that if it's then seen as the NHS's role to fix inequalities, we're doomed, because actually we know that whilst the NHS picks up the consequences, as does police, as do lots of other bits within our local authorities, we can't change it all through doctors and nurses and the health service itself. And I think it's how do we make sure that we have, exactly as we've talked about earlier at the summit, with the community-based assets, but also the private sector, how do we make sure that this goes across combined authorities and wider, because this needs to be a discussion in society rather than a discussion for the NHS particularly. And it's just making sure that the NHS doesn't attract blame for inequalities when it is only a very small part of the solution.
Yeah, I mean, I think that's a really interesting debate to have in many ways, because I think you're right. Inequalities, I think, it's been the bread and butter of local government for years, and you know, the wider social determinants. And suddenly the NHS, we start talking about health inequalities, which actually we've been told we're waiting on a white paper on health disparities. So even the health inequalities language seems a bit dated now. It's not our area of expertise, but I do think we do have a role to play. We absolutely do. And I think about, if you just think about our hospital and community-based services, thinking about the design of our pathways, if we're really serious about tackling health inequalities in our communities, really understanding the data, who's accessing services, who's not accessing services, is the design of our services meeting the needs of all of our communities. And I think probably one of the areas we learnt the most in the NHS was through the COVID vaccination programme. So getting that data, and actually we need to make sure that our NHS services are not just shiny services waiting for the right referrals to come, but we are maximising their benefit for our local communities. So I think in part we do absolutely have a role to play, but your point is well made, Alistair. We can't fix this on our own. It has to be a shared endeavour, and you're quite right. It's a conversation we need to have with the public, and I think probably through the creation of our health and care strategy, we'll be able to have some of those conversations together.
Please.
Can I speak?
Hi, I'm Suzanne Lamb, and I'm Deputy Director of
Yes. I'm Margaret Young, Deputy Chair of Health Watch, and I've worked in health and social care for 55 years within Northumberland. So I've worked in every area of Northumberland, and I've managed change. Change happens on a daily basis. We can't stop it. My problem with it is, who's going to monitor this change, and is it going to cover everybody? Because we're not just a health problem, it's a social care problem. And there is pockets within Northumberland where there is no service hardly.
So
And I worry about that.
yeah, no, that's understandable, and I'd love to have a chat with you, Margaret, with your years' experience. I'm sure you could tell me a few things as well. So who monitors this? Integrated care systems will be inspected by the Care Quality Commission. So that will start probably in the next 12 to 18 months. They won't rate systems like Ofsted rates a school or the CQC rates a hospital at the moment, but they will produce a report, and they will be making sure that we are assessing on how we're doing and delivering some of the outcomes that we've been set.
I'm quite happy because I've worked with CQC as well. But the point is, at the minute, I've got a problem. I've run a social group, for 5 years now within a primary care setting. And I've had to show them how to fill in forms, answer questions and one thing. No, I don't mind doing it, don't get me wrong. But now we're getting more digital. And I'm not all that au fait with digital either, but I do know the basics. It's becoming a big problem for me as well as them, because I can't show them everything.
Yeah, no, I really have. I think the whole digital kind of inclusion angle, and We also know that there are still people who don't have access to the internet as well. That's another issue with the rural areas, and virtually everything's gone online now. So I'm sure, as from a Health Watch perspective as well, that'll be something you'll be looking at. So maybe we could pick up a conversation afterwards. Yeah.
Suzanne, please.
Thanks. So I'm Suzanne, and I'm Deputy Director of Nursing with Harrogate and District Foundation Trust, and we've been involved in tackling health inequalities in the service, in a health service, for as long as I can remember in the particular service that I'm involved in. And we've worked together really effectively over the years with partners, and to different extent in different areas, but by and large, you know, we can remember different political objectives that have come in which have supported good integrated work. And the block seems to be sometimes the systems change before you get to the point where you see the outcomes. So you can never actually demonstrate what's worked well or hasn't worked well, because you have all these different political systems over the top of them before you get to the point where you can measure. And the long-term outcomes are ones you're probably not going to see for 18 to 20 years. So I suppose my concern is really that, one, what's happening in the interim, because, you know, decisions need to be made right now. And how can we be sure that this will be sustained and will make a difference?
Well, I think, to respond to your last point, Suzanne, I think it'll depend by the people within the system, really, around whether it's sustained or made a difference. I don't disagree with you in terms of some health inequalities and some of the measures. So if we look at life expectancy and quality years of life, the Health Foundation was saying some aspects that could take up to 75 years, actually, to move. Having said that, there are other areas and other outcomes. So if we think about smoking, if we think about respiratory, if we think about encouraging pregnant women who still smoke, there are some things actually you could address relatively quickly. So I think there's a spectrum, isn't there, in terms of the outcomes that you want to tackle, what the impact is, and over what period. And I think if I was to go back to the work here in Northumberland with the Health Inequality Summit, which has been about looking at the health inequalities, trying to funnel that down then to, well, what are we going to focus on? What are the outcomes? What are the specific actions? I think we'll have a spectrum there. You'll have some that you could actually deliver on quite quickly. Some will literally take years and indeed go on beyond our lifetime to some extent, and our careers. So I think it's very much about what out of those health inequalities we focus on together. What are we trying to shift? And there'll be some short term, and there'll be some that just will take much longer. Let's be honest, if you look back in history, at some point there'll be another structural change in the future. Something new will come along. So I think it's incumbent upon us to seize this opportunity that we've got right now, to be really clear about what our priorities are. We will not be able to do everything. We will not be able to tackle every health inequality in our communities. Where are the ones that are going to have the biggest impact? Our children and young people, they are our future. Thinking about years of quality life, respiratory illnesses. One of the reasons why we have lower life expectancy is because of respiratory illnesses. That's a really big issue for us. Drug-related deaths is another. So I think it's about some of those choices we're going to have to make together, prioritising those and being really, really clear. And what I would like to see across the North East and North Cumbria is, in our 13 places, of which Northumberland is one, Northumberland being very clear about which of those health inequalities we are going to tackle, how are we going to measure it, how will we know if we're making progress against each of those.
Thank you. Any other question? To Sam? Jeff? No? Thank you very much, Sam. Thank you for answering all the questions. Thank you.
Chair.
It's
so
wonderful.
I'm going to leave the clicker here for future presenters, and I'm also staying if anybody wants to catch up at the end.
Yes.
Thank you.
Thank you. Right. So we want to move on to the next item, which is it's a presentation by Dr. Catherine Bush. It's on needs assessment of benefits and debt advice for Northumberland. Thank you.
Thank you. Can you hear me? Is that on? Yeah. Okay. So hello everyone. My name's Catherine Bush and I'm Public Health Registrar. And today I'm going to present to you a piece of work that I did whilst I was working here within the public health team. And this was a health needs assessment of the benefits and debt advice needs of our Northumberland population. So this health needs assessment was carried out at the end of 2021. And just as a bit of background, a health needs assessment is a systematic method for identifying and reviewing the health needs or issues of a specific population. And to let you know the context that this was done within, the public health team at Northumberland County Council provides funding towards the core generalised advice service and specialist benefits advice that's provided by Citizens Advice Northumberland. So what I'm going to do today is take you through some of the key findings from the report, the types of needs that were identified and the implications we see from the report. So with this needs assessment, we started off at looking at something called normative needs. So this is the published evidence and expert opinion on the topic. And the Marmot reports have really highlighted the links between income and health. We know that people who live in our most deprived areas live shorter lives and they live a greater proportion of their lives in ill health compared to the people that live in the least deprived areas. And as we know and as we've talked about, this is what we call a health inequality. And as Sam also mentioned, the 2020 report highlighted that the North East is the only place in the country where life expectancy for women is actually falling. So we know that the health of our population is deteriorating. So what can we do about these inequalities? Well, one aspect that we've looked at is welfare and benefits and debt advice. And the reason for that is that the literature shows that welfare advice can improve health. So it improves health in the obvious ways. So if you have more money in your pocket, you can afford to heat your home, you can afford to buy food, you can afford to live. But it also has other indirect benefits as well. So welfare advice has been shown to lower stress and anxiety, to improve people's mental health. And when people are kind of not worrying about money and their welfare problems, they're better able to engage with health services. They're more likely to stop smoking. They're more likely to be able to exercise. And this is just to highlight the fact that there is a two-way relationship between debt and health. So we know that debt problems can lead to deteriorations in mental and physical health, but health problems can also be a trigger for increasing debt. So some people with psychiatric problems may not be able to manage their finances, or they may have significant costs associated with health or be unable to work. So this is a report that we looked at that was done by the Department for Work and Pensions. So it was published in 2020 and it looked back over the year 2017-2018. And what the DWP found was that nationally around £7.1 billion worth of benefits went unclaimed each year. And that only included a couple of benefits that they looked at. So what we did was we took that estimate and we applied it to our own population to try and work out what that value might be to Northumberland. And what we found was that it could be as much as £31.8 million per year of benefits which go unclaimed in Northumberland, which is obviously a lot of money, and there will be different reasons why those benefits are not being claimed. But what the research shows us is the main reasons are that people are not aware that they're entitled to some of the benefits, so they don't claim them. But also there's still a significant amount of stigma, embarrassment, shame, which is associated with claiming benefits. And the final just piece of information to draw your attention to is just thinking about the increase in inflation and the overall cost of living. So we know at the current time the cost of everything is going up, and when we look back at previous economic crises within this country and elsewhere, we know that people on the lowest income are those that are most severely affected by rising costs. So then we think about what we call comparative needs, so how we compare to other places. And what we've done here is highlight some of the main inequalities in Northumberland compared to elsewhere. So Northumberland's geography and widespread rural population, as we know, presents really unique challenges in terms of trying to deliver services equally across the county. We know that healthy life expectancy in Northumberland is lower than the national average and is reducing, and that suicide rates are higher in Northumberland than the national and the North East average. And a local report that looked at suicide within the North East showed that there was an association between debt and suicide, and particularly cumulative debt issues, so people who've got multiple debt problems. When we look at how the North East compares to elsewhere, it has the lowest median weekly earnings in the country. So what that means is people in the North East who are working full time are earning less than anywhere else in the country. And the final thing just to draw your attention to is that Northumberland has a higher number of children living in poverty in working families than in non-working families. And that is across the county as a whole, but also for each individual ward within the county as well. So then we moved on to thinking about felt needs, so what people say they need or what people say they want. And for this, we looked back at the 2015 resident survey in Northumberland. So this has been done a little while ago now, but it's the most recent survey that we had access to at the time. And what that showed us was that adequate income or financial stability was one of the top factors that our residents within Northumberland highlighted as being one of the things that contributed to the health and well-being of their families. But worryingly, within our population at this time, 14% of people were having difficulties paying for their bills, 9% said they were having difficulties affording to buy food, and 2% were reliant on high-interest money lenders, so that's kind of payday loans. We were also thinking about access to services. So one thing we looked at here was internet access, and back in 2015 when we did this, 19% of our community did not use the internet at all, and most of those people were older, social tenants, disabled, or living in the southeast area of the county. So we then performed a new survey as part of the health needs assessment, and this was run over December to January. And what we aimed to do with this survey was look at what people knew about within the county in terms of advice services, what people were using and why perhaps they weren't using services. What we found was that citizens' advice was the most commonly named source of advice, both for people that had used services but also people that had never accessed them. And the health benefits of good advice were really highlighted by residents within the survey. So it really reflects the literature and kind of backs up the literature in that people talked about how good advice they'd received really kind of reduced their anxiety and improved their mental health. And benefits and debt were two of the top 4 reasons that people contacted advice services. Other things were around employment and also energy bills. But we know that some people needed advice and didn't access the services. And around 8% of those were people who needed advice but didn't know where to get it. 6% were worried about confidentiality. And others, so less than 6%, had difficulty accessing the service or were put off by embarrassment or stigma, as we call it. So finally, we looked at express needs. So this is which services people are currently using. And in order to do that, we did some mapping of advice services within the region. And what we found is that there are many organisations within the region which are providing basic budgeting and financial advice, which is fantastic. but they don't provide specialist benefits advice and they don't provide advice on debt management. So most of the smaller organisations would provide that basic advice, but then would refer on usually to citizens' advice. We do have some organisations within the county which are providing specialist benefits or welfare advice to specific groups. So we've got Carers UK, and we have other groups such as Alzheimer's UK, so other people with specific health problems. But just to summarise the other kind of services that are provided within the council, so we also have Northumberland Communities Together, which you'll all know was set up as a response to the COVID-19 pandemic. And we've also got the Northumberland County Council's Welfare Rights Team, which mainly provides advice and training to care managers and social workers. And then we move on just to talk about Citizens Advice Northumberland. So it's the only provider within the region that provides a universal and free service which covers benefits and debt advice to our population. And during 2019-2020, they gave advice to 22,500 different people. And Citizens Advice use very robust methods for estimating the impact of their service, and that's done both nationally and locally. And you can see from the slides here that their estimates around their benefits in terms of fiscal benefits, public value, and the value to residents in Northumberland. And this included helping to secure £4.5 million in welfare benefit gains. So that is £4.5 million which would probably not have been claimed if people hadn't accessed the advice services. And then we just want to focus on the potential unmet needs that were identified by this report. So one thing we found is that between February 2019 and January 2020, on average, 51% of calls to Citizens Advice Northumberland went unanswered, and that is purely due to service capacity. So despite the fact that Citizens Advice are actually answering more calls than ever before, the number of people that are calling has risen so exponentially that they've been unable to keep up with the number of calls they've been getting. And the pandemic has resulted in an overall increase in the number of people requiring and accessing services. So those numbers are continuing to grow. Local services within the region that we spoke to as part of the health needs assessment reported that they were seeing an increase in contact from working families who were just about managing pre-pandemic but were now facing significant financial difficulties. And the thing about these families is a lot of them have never accessed benefits or welfare advice before. They don't know how to access the system. They don't know what they're entitled to. And we'd just like to finish by highlighting the challenge of meeting the needs of our rural population. So what did we feel the implications of this report were? So we looked at all of the evidence that we found, and we believe that the advice services in Northumberland were not currently meeting the needs of the population. And that need is just going to continue to increase. And from our perspective, we think it's vital that we provide adequate advice services so that people can get the help that they need, can access an income, and that can improve their health and help them to thrive. So as a result of the health needs assessment, we made the decision to increase the core funding for the service and also to invest in wider capacity building over the next 3 years. And the planned investment will increase from £420,000 per annum to £520,000. And then we come on to our recommendations for the board. So what we'd like the board to do today is to consider whether or not, to consider where advice services fit within the broader inequality strategy and whether or not we should be further supporting advice services within that strategy, and also to discuss the contribution of our partners within the region around supporting access to welfare and benefits advice for their staff, their patients and their residents. Thank you.
Thank you very much. Are there any questions, suggestions over what we heard from Dr. Catherine Bush? Alistair, yes, first.
A great report and obviously a very important issue. I think the only thing I'd probably add is that there's also quite a lot of hidden support that's already there. For example, as a trust, offer debt advice for all of our staff, clinical and non-clinical, and so there's already quite a significant contribution in kind for that. So I think that's really important to acknowledge. But I think the other thing that I'd say is primary care. The social prescribing within primary care, an awful lot of the activity that I observe for that is actually around debt management and the same sort of issues. So already, compared with when the report was first written and now, there is a significant amount of activity going on with regards to social prescribing, looking at how they can actually access debt services as well. So the reason I think both of those are worth thinking about is they are actually further augments and contributions in different ways to the totality of the picture, which has got to be welcomed.
Yeah, thank you. I mean, it's great to hear about kind of any new initiatives and any improvements. I think the one thing we need to think about is that that offer isn't at the moment universal, so different people in different areas within the region will be receiving different services, and we need to try and ensure equity within the region with that.
Wendy.
Thank you very much. That was a really interesting report, I was particularly interested in the 19% of people who are not accessing the internet. I think some of that will be the extra charge for it. And, you know, for anyone who is disabled, online shopping is such a valuable thing, and in the winter in particular, I just think we need to do a bit more around that. So Communities Together sits within my portfolio, and they're a fantastic team. I'm very proud of them. I'm like a proud mother with them. And although Citizens Advice are absolutely marvellous as well, I'm really going to speak with Communities Together about this 19% and how we can try and see how we can stimulate some activity in that. But thank you very much. Citizens Advice, incidentally, and I've mentioned this before to Liz, I sat through a movie a few years ago called I, Daniel Blake, which was set in Newcastle, and it was terribly sad about this poor man who lost his job and he descended down, couldn't get a job anywhere. And all the way through the film, I thought, go to Citizens Advice. Go to Citizens Advice. Never did. He never did. And that was a flaw, I think, in that film. But yes, Citizens Advice, I'm fully appreciative of everything that we do with that.
Thank you. Yes, please.
Good morning. I'm Travers. I'm the Group Director for the North area for Northumbria and North Tyneside for CNTW. There were a couple of things. One, I think there is a real concern. I mean, the digital one that you talked about, Wendy, was 19% in 2015, I think. Would be really interesting to see where it is now, because we have been on a wave of digital technology and change. I don't know about others, but I despair in spending on digital technology, so most of mine won't even link in now. But I think that there's an expectation that everybody can get onto a digital platform, and we can't. And I think that's one of the things that, as we're developing, we need to think about how we give people access to digital technology, places for people to go, so they can access without having to pay. The other things I think is that there is definitely a wide I would pick up as well. We do a lot of work with access to housing, but also access to benefits for individuals. We see within people within crisis, it's not always a mental health classic crisis and a deterioration of their mental illness, but actually we see people in crisis quite often what we would class as a social crisis around housing and around money. A lot of individuals have really suffered during the COVID-19 pandemic. We've got a lot of areas without employment. So I think it's wider than just looking at finances, and I think that we do need to work together in making sure whatever we do includes this kind of development, and I'll be taking it back into the community transformation work we're doing in Northumberland.
Yeah, thank you. And I think we're not under the illusion that this on its own is the answer to the problem, but I think it is just a part of the jigsaw.
Thank you. Yeah, I'll come to you next.
Thanks very much. That's very interesting. I just wondered, and I don't know how realistic this is, about whether there'd been any thought with working with partners around the sort of principle of making every contact count, so that, for example, a health visitor goes into somebody's home and they won't have that knowledge and expertise, but they would have the knowledge about health needs assessment, assessing the situation, and actually then making that leap to signposting people, but doing that in a very sort of professional way and sensitive, helpful way. And I just wondered whether there'd been any thought around whether we could do some joint work with that in mind.
Yeah, thank you. That is definitely something that we've been thinking about in this report. So there is a much longer version of this report that you'd be welcome to have a look at, but also in terms of thinking about the recommissioning of the service as well, thinking about making every contact count from kind of in both ways. So thinking about from the advice services perspective, if you've got people presenting with kind of debt, suicide, financial issues, making sure they can be appropriately signposted to health services, and then from a health services point of view, trying to improve the ability of health workers to recognise those people that might need to be signposted to advice services, because I think it's something which isn't taught at medical school, it's not taught at nursing school, but it's really important, and often the kind of we've previously thought about kind of people on benefits being at risk of kind of financial problems, but now kind of really highlighting the fact that a large proportion of the people that will be having problems will be in work, and they will be working families, and thinking about how we recognise those people is really important as well.
Jeff, and then you, and then Susanna.
Yeah, Jeff Watson, I'm responsible for Healthy Lives for Northumberland. The statement about the lowest median weekly earnings in the country in the North East, it's a very interesting one. Unemployment level in Northumberland has certainly been reducing down to about 4% now, which is the best it's been for years. And I think you're right what you said before. Health is not something that we can sort of prepare to try and do something about it, but the core of good health is work, is employment, is production of wealth. The question that always strikes me is, when I go around the country, I don't see the North East as being so much worse than anywhere else in the country. And I just wonder, the cost of living, I think we would agree, in places like London, is an awful lot more than the cost of living in Northumberland. You know, our rents, our beer, our fish and chips are all a lot cheaper here. Does the lowest earning mean very much if you don't compare it against the cost of living in the area that you live in? I mean, if it's cheaper to live in Northumberland than it is in the South East, then you can make less money and still be as comparatively as well off. I've never seen any figures that compares that. What's your view on that?
Yeah, I think it's a really good point. I think we can look to kind of our near neighbours. So we can look to kind of other kind of areas within the north of England. So we can look at kind of Sheffield, Manchester, Leeds, where I think the cost of living is probably more equivocal to here. And we know that people within the North East are earning less than those areas. But I think the other thing that we have to look at is the health outcomes. So we can see our health outcomes are worse, and we know that one of the contributors to that is low income. So we're seeing the evidence in terms of our health outcomes, even if we're not seeing it kind of on a day-to-day, when you look around basis. That would be my view.
Thank you.
Health welcomes your report. They quite like the report. But what we've found from the public is it's the difficulty in completing the forms and getting face-to-face people to help them to do it. And we asked a wide group of people how they accessed, and a lot of them found it difficult to get through on the phone and where you're based. And we wondered why there wasn't a hub in the town centre, because what we've got to look at, if they've got to get a bus to where you are, then they might not be able to afford it. So that's not equality, is it, really? So why don't we have it in a town centre where they used to have one in the town centre, where people just could walk in? I just wondered if there was a possibility of looking at that, because then you would probably meet more people and they wouldn't be embarrassed because it would just be on the high street. Let's talk would be the thing on the front. Do you know what I'm getting at?
Yeah, absolutely. So I think we looked at that, and we looked at kind of how people are accessing citizens' advice. So that they do have the different ways. So there's the telephone, which we know people are struggling to get through on. There's the internet, and then there's the face-to-face appointments. And there were different hubs throughout the region. But one thing that was kind of brought up in our survey was that sometimes the timing of those didn't really work for people who were trying to access them through public transport. So the Berwick one, for example, people said they found that difficult. So that's something that we talked about with citizens' advice in terms of thinking about that from an access perspective. I think citizens' advice made the decision, I think it was back in 2017, that they couldn't provide with their current funding the level of face-to-face service they'd done previously, and that's when they moved a lot of their provision towards digital and telephone services. But I think you're absolutely right that there's a big group of people for whom face-to-face contact is the best thing.
It just helps such a lot of people that need your help. Vulnerable people who need your help cannot access it because of the locality. And that, I think, is a big problem, especially because of the geographical area of Northumberland.
Yeah, and I agree, and I think the other issue is that there's no one-size-fits-all. So for some working families, actually, the telephone or the internet is the best thing. For other people, having it in the town centre is the best thing. And I think there's no one-size-fits-all, and we need to work to continue to try and provide a kind of as wide a service as we can for as many people. I agree.
Prior to the pandemic, the group I run at the primary care centre, I invited on a 6-monthly basis Edu-K, you name it, and we used to have a lot of people, and people came and found out information. But since the pandemic, no, I haven't had time to do things like that. But why aren't we going round to the groups? There's lots of groups going on within Northumberland where you would access people. Yes, we have the social prescribing people in some of the primary care sectors, but they do not meet them all. Mm-hmm. I'm just thinking of ways that you could get around.
Yeah. Thank you.
Sorry.
Thank you very much. I think Suzanne, followed by Alistair.
Yeah, it was just to touch on the point that was brought up about health visitors being ideally placed to do that. I think it's not just about health visitors now. A Norton 19 service has multiple roles that are non-health visitor or that level, and it's about introducing roles that can pick up that level of work that addresses the rurality. It allows the proper targeting to make sure the right people get the right message. The issue that we've had in the past is that there isn't a consistent approach to ensuring that those staff are trained, because this is, it changes all the time. So you have one-off piece of training, then the advice changes. You need a consistent training programme in which people are constantly updated, and then they can make every contact count accordingly.
Thank you. Yeah.
Alistair.
It's just two observations, and I think we do need to be cognizant that there is variations in the cost of living, but utilities, supermarkets are universal. And I'm always struck by the fact that whenever you describe Morpeth, locally people view it as a nice, affluent town. It's seen as a jewel in Northumberland. Liz will correct me if I'm wrong. We are national average for our deprivation if you look at Morpeth. And I always use that as a grounding, because if that is seen as the affluent bit of Northumberland and that's national average, that shows where the benchmarking is in some other parts of the country. So I think that's something that I think just helps ground things when we actually do look at the degree of deprivation in the North East. And the second point is I do think that we probably do need a deeper dive into digital inclusion, partly because I think it changes so rapidly with smartphones. A lot of people will not access the internet as they view it, but will access social media, which is the internet, but may cognitively dissociate one from the other. But I think as we go forward, it's really important that we do get a view of what is happening with regards to that and what's the age profiling of that. Debt may be predominantly around working age adults who may have better access to the internet than an older population. We've just gone with a digital solution for handheld maternity notes, which has offered smartphones to any user that wants them who hasn't got one. And we've had zero uptake, and that reflects that particular demographic of young women who could be pregnant. So I think it's something that we probably should delve into because I think it is quite relevant as a health and wellbeing board. So it's just 2 observations.
Thank you. Any more questions? Right, Liz.
Thank you. It was just to pick up on your point about variation and in terms of the provision of welfare and benefits advice within NHS partner organisations. And I think this is probably something that we can pick up as part of the ICS strategy so that we do have a consistent approach within our organisations in terms of providing financial and other wellbeing advice, not just for staff actually, but also for patients and contracted workers as well. I think that would be hugely beneficial.
Sorry, my final comment was just to try and clarify the ask. I wasn't sure at the very bottom of this there was a question mark about...
Is this a commissioning question, and are people willing to look at how this is commissioned, because there's a lack of a service here, and how do we take that forward?
So I think it sort of relates to the point that I just made, really. So, for partners within the room, primary care, our 0 to 19 services, NHS trusts, actually how can they, as organisations, make sure that financial wellbeing benefits and debt advice, appear on their radar, and what contribution can they make to ensuring that staff, patients, residents can access that within their organisations, or at least signpost to services which are in place.
Thank you.
Thank you.
Thank you very much. So we move on to the next item.
Thank you. So I will try and make it brief as well. So we've obviously had this wave of COVID over the last couple of months. That's now falling off. So according to the ONS surveillance data, those prevalence rates are falling from 1 in 20 to 1 in 25. As you'll appreciate, it's not falling particularly quickly. And that's the data that we got for the week up to the 26th of July, I think that was. So it's falling in all regions and it's falling in all age groups. Across the region, hospital admissions of people with COVID and bed occupancy of people with COVID is all going down, which is good, and that just reflects community transmission. Also, on a positive side, we don't seem to be seeing any new variants bubbling up underneath, which is really good. I think the key messages going forward are still about wearing face coverings in busy public places. 1 in 25 that's still a lot of COVID, which is floating around in our community. So continue to wear face coverings in enclosed busy spaces. Isolate at home if you're unwell, and you can do hand washing, and all of those good respiratory hygiene behaviours are still really important. But obviously the most important thing we can do
is to get ourselves vaccinated. And I know Rachel was just going to give us a short verbal update on where we are with the vaccination programme.
Hi, thanks Liz. So just from an update on the Spring Booster programme, so we're at 87% uptakes, probably slightly higher than that now, of all our eligible populations, which is very comparable to the first booster uptake. From a point of view of 75 pluses and the immunosuppressed uptake, we are above the North Cumbria average in Northumberland on that. From a care home perspective, we're still slightly below, but our PCNs have confirmed that they have made offers to all patients and continue to mop up and continue to vaccinate those patients. And some of that is just around patients being unwell at the time that they were in and waiting for them to recover, etc. We're still offering that evergreen offer across all cohorts, so that's still available across all our sites. There is a huge amount of work going, as you can imagine, in preparing for the autumn and the winter campaign. So JCVI have now confirmed that the COVID booster will be offered to all ages over 50 and all those in those at-risk groups that we'll be familiar with within the cohorts 1 to 9. The flu vaccination programme has also now been extended to include the over 50s. They were the under 50s. They were previously excluded from flu, but they've now been included within the programme. We have got a good response from all our primary care colleagues to continue, and so we've got all but 4 practices have opted in to deliver the autumn programme, which is brilliant, and we've also got really good expressions of interest from community pharmacies, which will also support that programme. We have got one GP-led vaccination site within each of our PCNs and additional coverage, again, through community pharmacy and our roving model, which we know has been really successful in reaching our rural communities. Our current estimated start date is the 12th of September, but we will still, that remains to be seen whether that will happen. Obviously, we continue to wait for confirmation around that, but that's the sort of date that we're planning for. We are expecting a new modified vaccine, which is being produced by Moderna and Pfizer. And again, we're just waiting for that to be approved and to go through all the relevant committees for sign-off. There is a 91-day gap between the most recent booster before the supply of the next vaccine. And it's going to be quite difficult this time around because people have now had so many vaccines. I think that would be quite a challenge for people to know which vaccine they've had and etc. But our first group of people, obviously, that we will be prioritising will be our care homes and our housebound patients, which we've always done in the past. But bearing in mind some of those haven't been vaccinated, there's going to be there'll be a constant sort of mop up, I would think, of the programme. Our obvious desire is to co-administer both flu and COVID, but that was a challenge last year and I think will be a challenge for this year as well, just because of the different arrangements in which flu comes to the primary care practices and in which the COVID is delivered. So we will try and co-administer where we can, but it is likely that people will have the vaccines at different times, just so that we don't delay the rollout of that. And we'll just continue to work really closely with primary care, who have done a phenomenally great job at delivering this, and our community pharmacies. And that's really all I can update you at the moment.
Thank you, Liz. Thank you, Rachel, as well.
Just a quick question, a very straight one. I may have missed it, but have we managed to manufacture a vaccine that includes COVID and flu yet? No, okay. Are we looking to hopefully get that?
Well, I think we'd all love to have that, actually, but no, I think we're quite a long way off that. But
okay, thank you.
Any further questions? Thank you very much. Okay, we move on to the 7th item, board development session review, to be led by Graham.
Thank you, Chair. I'm afraid there's 4 slides, but I hope that we'll be fairly quick with this. Thank you to those people that contributed to the development session last time, and thank you to Jill O'Neill, who took the notes and prepared the slides for me to feed back today. So the idea was we would have that development session, we would bring back the findings, and then we would agree formally what the next steps were. If you remember, there were 3 questions that we asked in the development session. One was, is the Joint and Health Wellbeing Strategy still relevant? 2 was, how do the scrutiny committees relate to our, the scrutiny committee and the Health and Wellbeing Committee relate to each other? And the 3rd one was, how does our System Transformation Board, have I not got my thing on? I'll put that on there. How does the System Transformation Board and the Health and Wellbeing Board dovetail with each other? The first slide, then, where's the Zappos? Can somebody just move it on for me, please? Thank you. So the outcome was, yes, we felt that the strategy does remain fit for purpose and is a strong strategy for Northumberland still. The 4 themes identified in that strategy are still the right themes, and just to jog your memory, they are giving children and young people the best start in life as number 1. Number 2 is empowering people in our communities. Number 3 is tackling the wider determinants of health, or some of them. I think that's a case of not being overly ambitious, but being ambitious. And number 4 is adopting a whole system approach to health and care. And I think that fits well with where we know we need to be going anyway. We did agree that the membership of health and wellbeing does need to be reviewed with a view to thinking about how we work into those 4 themes, and the attendance requires a review to ensure that there is a full system-wide participation at health and wellbeing. We need to appoint an executive lead member for each of those 4 themes to ensure that those themes do get appropriately managed through our systems. There will be an element of determining which of the objectives within the themes fit with our emerging inequalities plan. And the inequalities plan is in draft form and will be coming to the Health and Wellbeing Board next month. We do need to refresh some of the metrics because they are old metrics within it, so that needs to be looked at. And it also needs to be including some of the markers that will come from the inequalities work as well. Also, we feel that the Health and Wellbeing Board needs to become a much more seen part of our system in terms of how we drive this element of discussion forward into our provider partnerships that we'll be working through System Partnership Board. Next slide, please. The questions around scrutiny. I think we had a good debate. Veronica, who's gone, was with us on the day. And actually, Chris Angus, who organises the scrutiny within the council, took us through actually the legal requirements of scrutiny, which was very useful. It's right and fair that OSC can call any topic in to be scrutinised as part of their work plan. It does have an overview role, and it should and can be proactive, but at times it needs to look at things retrospectively as well. But with relation to Health and Wellbeing Board, we felt that it would be sensible to have an annual report from Health and Wellbeing Board, which is automatically going to be considered by OSC, so that we are knowing that we will be scrutinised on our progress, and ideally the executive office of the themes will be working to that timetable. And this is about forming a battle rhythm, as Rachel was talking about the other day, about where we need to work our system through, and we know where things will be looked at and as they arise. And I think that will create a smoother system, if you like, but still with the appropriate level of scrutiny. Next slide, please. The last bit is about this emerging relationship between Health and Wellbeing Board and the system and the ICB. And I think Sam very well described how our Health and Wellbeing Chair will be attending a sub-ICP area. It's going to be important that our joint health and wellbeing strategies got compared to the other ones in our area, which go to creating an overall picture for our ICS, and our partners should be working together very much around those economic factors, around the wider determinants of health especially. We believe that our System Transformation Board, if that's the right name for it in the future, we did have a development session for the System Transformation Board which Sam came to, will be a key part of making sure our providers work in partnership around these themes. And the themes that we identified need to be managed through that board as well. And I think how we develop our project management system to work across all our partners is going to be a key in this. And again, it comes down to the battle rhythm and how we work and where that fits.
There has been some national guidance about the ICSs, which I think if you read the 3 points, it fits with what we believe we need to be doing. So I don't think there is any problem in what the national agenda is around ICS strategy and what we are proposing to be doing in Northumberland and how a way of working in Northumberland should work. Next slide, please. So next steps for discussion and agreement here, hopefully. We believe we need a small task and finish group to take forward the plan of action. We need them to review the membership and actually think about who we need to formally invite to become future members. We need to bring the Inequalities high-level plan shared at board in September and think about how we therefore work from there. To consider if there are existing groups that could take ownership of the thematic areas. So we know we have a very strong area already in children and young persons working up, and that fits ideally with theme 1, and we've already embarked on that piece of work, and that was discussed at System Transformation Board last time. But there may be other areas that we can fit more or less, or need to add to or reflect on how it will work. We need an executive sponsor for each themed area to chair the subgroup, and it will cut across the STB and Health and Wellbeing Board. We don't want to duplicate conversations where we can help it, but the two boards need to be knowing what's happening and how that works. And especially for the elected members who are not within the provider element of the System Transformation Board, we do need to have a think at the System Transformation Board about that element of it and whether we need any elected member representation there or whether the assurance is provided at Health and Wellbeing Board along those lines. And it's about the communication that goes between the two, I think. And then we need to think about the metrics update and then perhaps have another development session around metrics. So there's some time frames being put on that by Jill, which is excellent. For me, I think it's really just agreeing who is the small task group and putting some names on that to take that forward and bring it back for the next. And I was sitting here thinking, shall I just shout out some names or do we just need some hands up? And I'm going to defer to the chair to let him decide how he wants to decide on that bit.
Yeah. Yes, I think it's important we have that subgroups as we planned. I think I need to talk to Glenn Sanderson and then which member, because there is one executive and also one elected member will be in each subgroup. That was what agreed. So I would like to see some diversity in political diversity as well. So I don't want everything to be taken over by one party. So I will talk to Glenn Sanderson and see which are the best members to be in each of the subgroups. And I'll come back to you on Liz. Is that okay?
And for a minute, for the small task group chair, sorry. Yeah. Liz, would you be willing to look at that?
Yeah.
I wondered about Rachel in that. Yeah. Would that be, and can we just leave that with you to think about that and liaise with who you need to do to come back? Would that be all right?
Yeah, yes. I think the important thing is that the executive lead doesn't necessarily have to be somebody from the council. We should make sure that we take
a sort of proper partnership approach
yeah.
to it. I mean, it worked before the pandemic. Actually, though, you know, they were working, but of course the joint health and wellbeing strategy, we'd only just got it up and running before the pandemic struck. So those processes that we put in place never really got the chance to get into any sort of battle rhythm. And of course, you know, everything has completely changed since then. But yes, Rachel and I can have a conversation, yeah.
And just I was very aware that we have some very important providers in the room who will want to contribute to yes. the themes, but what I didn't want to do was end up in a big discussion about putting names against the themes right now, but it's just to agree that we'll work through that over the next month and come up with that for September. Yeah.
That's a good idea. Thank you, Graham. Thank you very much. Are there any other views, suggestions, alternatives? So we are quite happy. So it's a work to be done, action to be taken in the coming month. Right, so which then allows us to move on to the 8th item, which is to look at the forward plan, to give any suggestions, see whether they are okay. So they are presented here from pages 27 to 34. Are there any suggestions comments, criticisms? Liz?
Could we put an update on the joint strategic needs assessment on
Jason, yeah.
for
October, okay. Any other? Okay. So we move on to the 9th item, urgent business, if any.
Can I just
Please.
mention that what you've been talking about is that are you going to be looking at the fact in Berwick there's quite a disturbance because they've closed 2 dentists there and they're having a big problem trying to find one. And the other question was, I'd been asked by some parents, where has all our school dentists gone? Because once upon a time there used to be at least one in each district. I know there's one in Ashington, but I'm not sure. I couldn't tell them where else there was any. So we've got a big problem at the minute, and it was brought up by the BBC on Monday.
Yeah, Liz, can you please?
I can't immediately answer the question about school dentists, but NHS England, who commissions dental services, did come to scrutiny, I think earlier in the year, to talk about the provision of dental services. We could certainly ask NHS England to come back and talk to us about what the plans are for dental services, but we'll do that, shall we? Yeah.
Yeah. Any other urgent business? Okay, so thank you very much. And date of next meeting is on Thursday, 8th September 2022 at 10 o'clock, somewhere here in the County Hall. Right. Thank you for attending. Thank you very much. Yeah.